a medical professional by himself. Okay, Dr. Tanka Prasad Barakoti is the Additional Health Secretary in Ministry of Health and Population and is currently serving as the Director General of the Department of Health Services. Dr. Barakoti has been instrumental in advancing child healthcare initiatives, and his leadership continues to focus on the equitable access, policy implementation, and enhancing Nepal's health system. I now would like to request Dr. Tanka Prasad Barakoti, a Director General and Additional Secretary of Department of Health Services, and a Chief Guest to kindly share his remarks in regard to the recently, just a moment ago, launched Kaleidoscope initiative.
Thank you. Director of Family Welfare Division, Dr. Vivek Lal. Ministry of Health, Kenya, Dr. Jin, Senior Deputy Director of Medical Services and Head, Reproductive and Maternal Health, Ministry of Health. Representative of Ministry of Health, Benin, Dr. Edith, Head of Reproductive Health and Family Planning, Ministry of Health. Directors of divisions and centers, directors of Provincial Health Directorate of Madhes, Lumbini and Karnali provinces, esteemed colleagues, distinguished representative from national and international organizations, and dear friends. Namaste and good afternoon. It is my pleasure to be with you today at the global launch of Kaleidoscope initiative, an initiative that aligns deeply with Nepal's long-standing commitment to sexual and reproductive health and rights, particularly safe abortion services. I would like to convey my appreciation to Family Welfare Division, AERO, Beyond Beijing, Committee Nepal, Visible Impact, WHO, and all our global and national partners for making these moments gathering possible. As a Nepal's Department of Health Services, we recognize our role, are committed to advocating for sustained financing for sexual and reproductive health and right programs, particularly in the face of global funding restriction. Expanding access to the safe abortion services in underserved areas and strengthening public health, public-private partnership to enhance service delivery. Nepal is happy to be the key partner in Kaleidoscope, and we look forward to collaborating to make the safe abortion services accessible, available, affordable, and stigma-free for all. I wish you all very productive workshop. Thank you. Namaste.
Thank you very much, Dr. Barakoti. The wishes are much needed at this point of time. We're now moving towards another remarks. This would be by Dr. Vivek Kumar Lal. Dr. Vivek Kumar Lal serves as the Director of the Family Welfare Division under the Department of Health Services. He has more than 2 decades of experience working with the government of Nepal. Dr. Vivek Kumar Lal.
Thank you, and good afternoon, everyone. It's a pleasure to be here with you all. First and foremost, I'd like to express my gratitude to our Director General, Dr. Tanka Prasad Barakoti. He had a flight to catch, but on our request, he has delayed it. I hope you will be able to catch it, sir. Thank you so very much for that. And again, as the Director of Family Welfare Division working for Ministry of Health of Nepal, it's a pleasure to welcome you all to Nepal and be part of this broad initiative, particularly in these turbulent times when sexual and reproductive health and rights are treated more as a political agenda rather than the basic, essential rights of a human being. So it's a pleasure to be part of an initiative which is rare in these times. You'd hear that everywhere the issues related to sexual and reproductive health rights are facing a lot of headwinds. The resources are vanishing overnight, and people are very, very hesitant to talk about the issues that were given so much of political as well as social priorities earlier. So during these times, it's a pleasure to welcome you all. It's nice to have representatives from the Ministry of Health of Benin, Dr. Edith, the head of RH and Family Planning Ministry of Health, Dr. Jean Patrick from Ministry of Health of Kenya, my own colleagues, the directors of divisions and centers, and I'm also thankful to our directors from provincial governments who have made time to be with here, the directors from Madhes, Lumbini, Karnali provinces, all the colleagues from the health sector here, the distinguished representatives from national, international organizations, and all my dear friends. Again, I would be reiterating some of the things which our Director General has already said. And if you look at the broader perspective, Nepal is always considered to be progressive in terms of ensuring the SRHR, the sexual and reproductive health and rights in general, and safe abortion services in particular. But when we look at ourselves and we see that we are far, far away from ensuring unfettered access and universal coverage of the sexual and reproductive health services and rights to all these citizens. And I think like rest of the world, particularly the low and middle income countries who need global cooperation, global collaboration and guidance in moving this agenda further. It's a very welcome initiative that we are having here, and Nepal is proud to be part of this Kaleidoscope initiative. And Nepal also has a very long-standing and proud history of collaborating between governmental and non-governmental actors. We do not, I must reiterate, stand on two sides of a table. I must again acknowledge the important role that has been played by all our non-governmental partners and stakeholders in pushing this agenda of sexual and reproductive health and rights. Without their advocacy and push, we would not have a safe motherhood and reproductive health rights at all. And it is through their support, their advocacy that we are able to, again, move this agenda further. We are trying to get further amendments in the acts that we have to ensure that it is ensuring that all the SRHR rights are respected, and it includes features such as decriminalization of safe abortion services. So there are so many things that we are trying to do, and my colleague, my maternal and newborn health section chief would be discussing in the further sessions. So I would not take it away from her. She is the expert who would be leading the conversation from our end. I would just like again to thank everybody for your presence. And again, it's just the start of the journey, and we are proud to be your co-travelers. Thank you, everyone, and I wish you all a very good rest of the day. Namaskar.
Co-passager avec vous. Merci beaucoup pour votre présence.
Thank you very much, Dr. Vivek. As mentioned by Dr. Vivek, our chief guest would be leaving, I think, in 30 minutes from now because he's delayed his flight, because he also needs to understand what's happening today and what the government and the citizen will get benefited from the very initiative. We're now moving towards our country-wise presentation, everybody, on the maternal and adolescents reproductive health and right initiative. We're starting with Nepal. Our presentation will start from Nepal. We all know that Nepal's government's remarkable effort in making healthcare free and providing framework for better access to safe abortion has made the country outshine as one of the best practitioners of sexual and reproductive health rights and services. In this context, I would like now to invite and take this opportunity to invite Dr. Gauri Pradhan Shrestha, Chief of Maternal and Newborn Health, Section of Department of Health Services, Ministry of Health and Population, Nepal, along to come to the podium. She has already come to the podium. She'll now be sharing us the current landscape of safe abortion access in Nepal. Dr. Gauri is also a senior obstetrician and gynecologist, having more than 2 decades of experience working with the government of Nepal. We're now moving towards Nepal.
Respected Chair Dr. Vivek Kumar Lal, respected Dr. Tanka Prasad Varakoti, and all the directors of Department of Health Services, directors of provinces Lumbini, Karnali, and Madhes, and all the participants in the hall. Namaste and very good evening. I am going to present shortly about the situation, and it is a very, it's our how our safe motherhood situation is favorable for us. Our national commitments come from the very beginning, from the Constitution. In 2015, our new Constitution has been made, and in Article 35, 30.3, 38, 38.2, 51, and 51.3 has talked about our rights. I will just mention that in article number 35, there are outlined to right to health care, and in article number 35.3, they mention about a right to reproductive health. And in article number 38, this article ensures various rights for women, focusing on equality, dignity, and protection. So in article number 3.8, they outline that every woman has the right to safe motherhood and reproductive health services. And in article number 51.3, safe motherhood and child health is outlined here. And next. This is a Safe Motherhood and Reproductive Health Right Act, which was made in 2018. So in Safe Motherhood Right Act, we have mentioned there are mainly they talks about right to maternal health service, free emergency services, protection from discrimination, SBA deliveries, obligation of the state, and accountability and remedies. So this is the book I'm showing, and Safe Motherhood and Reproductive Health Right Act 2018. There are 8 chapters, and in chapter number 4, they mention about safe abortion service. Please next. This is a chapter 4, and here the condition where women pregnant women can go for abortion. The condition were mentioned. First, pregnant women can go for abortion up to 12 weeks of pregnancy with the consent of a pregnant woman. And next is the up to 28 weeks of pregnancy with the consent of concerned woman. There are also conditions. The next condition is if the opinion of a licensed physician that if an abortion is performed, there may be danger to the life of pregnant woman, or her physical or mental health may deteriorate, or a child born will be impaired. And the next condition is in the case of conception in a result of a rape or incest. Next is up to 28 weeks of pregnancy. Next situation is who is infected with virus that deteriorates immune system like HIV, or suffering from any similar incurable diseases. And next is if, in the opinion of the health service providers involved in the treatment, due to fetal impairment, the fetus is likely to become non-viable or unlikely to survive after birth, or become deformed due to any genetic disorder or any other reasons. And we also have some commitments, international commitments. In 2018, CEDA recommended Nepal that complete discrimination of abortion in all circumstances. And in 2012, in circumstances where abortion is not against the law, health systems should train and equip health service providers and should take other measures to ensure that such abortion is safe and accessible. This was in ICPD 5. Next. And also next, we have in 2021, Universal Periodic Review, UPR, during 47th session, France has made us recommendation that decriminalize abortion and effectively protect the sexual and reproductive health and rights of women and girls. And Nepal has accepted this recommendation. And we also have our targets and goals. Our SDG goals, we know all. In 3.1, reduction of maternal mortality, and 3.7, there is universal access to sexual and reproductive health, reproductive care, family planning, and education. And in SDG 5, we have achieved gender equality and empower all women and girls. And 5.6 says universal access to reproductive health and rights. Next. And this is the figure we have taken from, in 2021, we have a census, and along with census, we have done maternal mortality study. And this is the new picture we found after that study. 151 per 100,000 live birth is our new maternal mortality ratio. And this is our national figure. And if we see in the we have 7 different provinces. And if we separate the provinces, we have different number, MMR. In the Lumbini province, we have 207 MMR, and in Karnali, we have 172 MMR. But if you see in the Bagmati province, there is only 98. This is a huge difference between the provinces. So if we see, according to maternal mortality ratio by ecological belt, mountain has 133 MMR, and hill, it has 159 MMR, whereas Tarai plain, it has 147 MMR. Next. These are our cause of maternal deaths. We have 32% of maternal death from indirect causes and 68% from direct maternal causes. Among them, obstetric hemorrhage is the leading cause of maternal death, whereas PPS is the leading cause. Then we have hypertensive disorder, 12%, pregnancy-related infection, 7%, self-harm, 6%, and pregnancy with abortive outcome or complication of maternal death by complication of abortion is 5%, which is quite a big number, and 1% from anesthesia management, and 11% from other causes. This is the number of listed health providers and health institutions. This is the latest data. And this is taken from RMNC's dashboard from Family Welfare Division. We have total safe abortion service sites are for medical abortion only is 1,683. MBA within 10 weeks we have 730. MBA up to 12 weeks sites we have 350. DNE MI sites we have 63. And we have total safe abortion services providers for medical abortion service, MA, for only 4,239. MA, MBA within 10 weeks, we have 1,420. MA up to 12 weeks. MBA up to 12 weeks service providers, we have 2,860. And DNE, MI service providers, we have 187. This is just how people are using safe abortion service. Just here, as already said, that safe abortion service was legalized in Nepal in 2002, and since then we are servicing safe abortion service, and this is 81 in last year only. Service was taken from, this is the data from HMIS, and service was taken by 105,000 pregnant women. And just I'm showing our partners. These are our partners who are working for safe abortion services. Next. And way forward, initiative to reform policies in the Safe Motherhood and Reproductive Health Right Acts, because we have some barriers. So continuation of free safe abortion services, training of health workers and capacity building of providers to expand safe abortion services, effort to reduce stigma by providing accurate information and creating educational materials related to safe abortion, conducting programs to clarify value and behavior change related to abortion for various agencies such as law enforcement, security personnel, and policymakers to reduce stigma, and collaboration to increase private sector participation. Thank you.
Dr. Gauri, thank you very much for the country's context presentation. Moving further with Benin now. Benin has made considerable strides by legalizing abortion in 2021 and launching the National Roadmap for Safe Abortion Access. I'd now like to invite Dr. Edith Jonathan, who is the head of reproductive health and family planning of Ministry of Health, Benin. She is a doctor and a public health expert in Benin with 17 years of experience. She will now share us with a vivid picture of the safe abortion access landscape in Benin. She will be speaking in French, so to all our distinguished personalities, you may now use the earpieces. Thank you.
Ok, bonsoir tout le monde.
Good afternoon, everybody. I am happy to be here and also to talk about, on behalf of the government of Benin and for safe abortion in Benin. Before doing my presentation, I would like to thank you all for this very good initiative, Kaleidoscope, which will allow us to remove the gaps that are present there since 2021. And thank you very much for all those who have taken this initiative and all those who think of health of young women and adolescents. I thank you all. So to start, we are going to speak about the policies that is put in place by the government of Benin and to launch the safe abortion practices. So the introduction is here. This is our country here, Benin, which is in West Africa. It's not really a big country. It's a small country, which is right next to Nigeria. We have a population of around 14 million. And as far as health is concerned, and our country has a demographic rise. And the fertility rate is 4.7 children per woman. And the contraceptives are 16.9%, their prevalence. And for adolescents and young, it's 5.6%. And for mortality rates of mothers, it's 391 deaths for over 100,000. And one of the reasons is clandestine abortions because the law did not cover that. And so clandestine abortions, they in fact, they represent 15% of the maternal mortality rates. And so the access to services for everybody has become a priority for all the ministries and for all the departments where we work. And so the government of Benin is not silent. So some initiatives were taken to provide safe abortion practices.
Donc, sur le plan politique,
So,
quelles sont les grandes
as far as
décisions qui ont été
policies
prises?
go, what were the big
Il faut
decisions that were
reconnaître que
taken
la
by the
santé de la
government? So we need to
reproduction est
know that
partie
the
du plan d'action du gouvernement béninois.
health for
Il y a
reproduction
une
is an
mobilisation
important
à point des ressources,
aspect
surtout
for
la
the
ressource
government,
financière,
and we did
pour
some
l'offre
resource
des services de la
mobilization.
santé de
We
la
increased them
reproduction dans sa
to
globalité et
offer
de
services
l'avortement
of
sécurisé.
health and
Nous avons
reproduction
signé l'année
and for
dernière
safe
avec le
abortion.
ministère des
And
Finances
last
un grand
year, with the
projet pour le
finance ministry, we
renforcement des
launched
services de
a
santé
big project
sexuelle
to
reproductive
strengthen the
financé par
services
l'ambassade des
for
Pays-Bas.
reproductive and sexual health,
C'est un
which
projet
was
qui
financed by
est autour de
Netherlands.
18 milliards de
It's a
francs CFA
project
et qui nous a
which
permis de renforcer le
really
plateau
allowed
technique,
us to
de
strengthen the
renforcer
technical
la
aspects
compétence des
of
prestataires et de mettre petit
how
à
we can do
petit en
capacity
place
building of
tout ce qu'il
service
faut
providers,
comme plateau
and
technique
also
et compétences,
as far
passage
as
d'informations
the
pour
technical aspects
l'effectivité de
and training
l'avortement
go.
sécurisé. C'est un
We
projet qui va
were
durer 5
also
ans.
tried to
En dehors de
we were
ça, nous avons
also
également un autre
able
projet
to provide
qui est intitulé
trainings to service
ISRHR
providers.
et qui
And
est le donateur inconnu que nous appelons
and
BFETS.
we
Et ce
also
projet aussi a
had
une durée
another
de 5 ans
project
qui nous
which is
permet
called
également
ESRH,
d'appuyer tout ce qui est,
which
tous
is
les
there for
aspects
5
de
years,
la mise en
and it
œuvre
also
pour
allows us
l'avortement
to
sécurisé.
look at all the aspects
En
of
dehors de ça, pour la
implementing a
réduction
safe
des décès
abortion,
maternels, il y a
and
plusieurs initiatives
for
ministérielles pour pouvoir
reducing
faciliter l'accès à ces
maternal
services. Et
mortality
une fois
rates.
encore,
We
merci à
also
Kaleidoscope
put
qui
in
va nous
multiple
permettre de
initiatives.
combler les
And
besoins que
again,
nous
once
ressentons
more,
depuis
Kaleidoscope is
2021
another
pour
initiative
pouvoir
that will
renforcer
help us
davantage
since
l'accès aux services
2021 in
d'avortement sécurisé.
providing access to a safe
Donc,
abortion.
sur le plan légal, en
So,
2021,
as
vous
far
allez
as the
constater qu'il y a eu
legal
des
program goes,
améliorations de
you can
l'environnement
see that
réglementaire.
there was an
Il y a eu le vote de
improvement
la loi
in the
2021 du 12 décembre
legal
2021,
environment. So we
modifiant et
voted in
complétant la loi
2021.
2003-43
On 20
mars
December,
2023
we passed an
relative à
amendment
la santé sexuelle
which is
et qui donne
related to
accès aux femmes et
sexual
aux
health,
filles
which gives
à
access to
l'interruption
women
volontaire de
and young
grossesse.
girls
On ne s'est
to
pas
have
arrêté là. Il y a eu quand même le
services
vote de la loi
to stop their
2021-11
pregnancy
du 20
by their
décembre
willingness.
2021, modifiant et
And in
complétant la loi
December
2003
2021,
du
there was
3
also an
mars
amendment
relative
for
aux
the
infractions
law of
commises à raison du
2023
sexe
of
pour pouvoir protéger
2003 of March
davantage les
related
filles et
to
les femmes
to
contre toute
protect the
forme de
rights
violence.
of
Et ça, le chef de l'État,
women
le chef de
against
l'État, le
any
président
kinds
Patrice
of
Talon,
violations.
suit de
And
très
it
près
was
pour qu'on
by
puisse
the
réduire
president
véritablement
and
les violences de tout
to
genre
see,
qu'on
we did
observe
follow
à
up to
l'endroit des
see that we
filles et
really
des
had
femmes en République du Bénin.
minimization in the
Donc,
violation of rights of women in
comment
Benin.
cette loi s'interprète? Je
So,
ne vais pas
how
rentrer dans tous
these
les détails,
laws
mais
can
par
be
rapport à
interpreted,
cette
I do not
loi,
want
dans
to
son
enter in all the
article 17,
details, but as far as those
pour
laws
l'interruption,
go,
pour avoir accès à l'interruption
for
volontaire de
the
grossesse, c'est à
this
l'agrément de la femme
intervention to
enceinte.
interrupt
Donc, la
the
femme n'a pas
pregnancy
besoin de
law, so the
l'autorisation de son
woman does
mari,
not have
d'une tierce personne, pour
need
avoir
to have
recours à des
authorization
services
from her
d'avortement
husband
sécurisés.
to
Mais cette
have
demande
access to
est
safe
quand même
abortion
aussi
services.
conditionnée parce
And
qu'il faut que cette
this
grossesse
also
soit
depends on the
susceptible
conditions
d'aggraver ou d'occasionner
of
une
pregnancy.
situation de
That it
détresse
was
matérielle, éducationnelle,
a very
professionnelle ou morale
distressing pregnancy,
incompatible avec
and that it
l'intérêt de
will
la
also
femme ou
aggravate
avec
the
l'enfant à
situation of
venir.
the mother
Mais
and also
l'interruption
the
volontaire de
child that is going to
grossesse
be born.
est seulement
And
envisagée
the
si cette
interruption of
grossesse est en dessous
pregnancy is
de 12
only
semaines
envisaged
d'aménorrhée. Nous n'avons pas fait état
when
de tout ce qui
it
suit. C'est
is
déjà une
before
petite
12
avancée.
weeks
Mais on constate
of
là qu'il y a quand même aussi des
pregnancy.
limites.
So we
Et
see that
progressivement,
there
nous allons
should, we
travailler
want to, of
à
course, be
améliorer.
progressive, but we believe that there are still
Donc, sur
certain
le plan
limitations that
institutionnel,
affect
on
the
a
health
créé
of mother
beaucoup
and child.
de structures,
So
dont
we
l'Agence
also
nationale
created a
des
lot
soins
of
de santé primaire, je
structures
parlais. Mais le plus
for,
important, c'est la création d'un
but
institut
one of the
national de la
first
femme,
is that we
dirigé
created a
par une
national
brave dame
institution for
qui
women,
assure et
which is
veille surtout
directed. The
à
director
la
is
lutte
a very
contre les
brave woman,
discriminations à
which
l'endroit des
is
femmes
who
et
is
des jeunes
fighting
filles
against the
en République du
discrimination
Bénin,
against
même devant les
women and
cas de
young
viol,
girls in
d'inceste.
Benin,
C'est
and even
cet
for
institut
cases
prend
of
en charge
violations and
tout le
rape,
processus
and
pour que réparation
also
soit faite
there
à
is
la femme ou à
there
la
are
fille qui
fair
est
we
victime
try to give
de quelque
fair
abus,
trials
que ce soit
and to the
sexuel ou
victim
d'autres
and
genres
also
que
for
ce
the
soit.
favor of
Nous allons citer
victims and
également
for
l'existence de plusieurs institutions
anybody else who
de
has need
promotion
of
des
those services.
droits de santé
And there is
sexuelle et
also
reproductive.
there are a lot
Nous
of
avons l'appui
institutions
de plusieurs
that
partenaires, nous
exist
n'allons pas
for
citer ici,
promoting
des
the
donateur
rights
financiers,
and
et nous
health
avons
of
également des partenariats avec
sexual and
les
reproductive health.
organisations de la
And we have
société
a lot of
civile
technical
et les
partners,
organisations
technical and
non
financial
gouvernementales.
partners. We have INGOs and
Sur le plan
NGOs who are our
sanitaire, nous
partners
avons
also.
élaboré
As far as
l'élaboration et la
health program
vulgarisation
goes,
des
we
directives
have
sur l'offre des
put
services
in
d'avortement
place and we have
sécurisé. Ça, c'est des
popularized
formations en
the
cascade qu'on
guidelines
fait à
about
l'endroit de toutes les
offering
parties prenantes
safe
qui
abortion
interviennent dans
services,
l'avortement sécurisé.
and
Le
we
renforcement de capacité des
I'll also
acteurs
try to
sur
strengthen
l'offre
the
des services
capacities, the
d'avortement
capacity building
sécurisé,
of all the
c'est-à-dire la
actors
formation des
who
médecins, des
are
infirmiers, des
involved in safe
sages-femmes,
abortion
pour qu'ils soient
services.
aptes à
For
offrir les
example,
services
even for
d'avortement
midwives, we
sécurisés,
try
même si
to
c'est la méthode
reinforce, we
médicamenteuse
try to
ou la
strengthen their
méthode
capacities,
chirurgicale,
their
que les
trainings,
agents de
or
santé
even
soient
for
aptes
medical,
à offrir
so
ces
that they
soins.
can even
Nous
help,
avons
even
également
in medical
travaillé à
surgeries.
l'amélioration du
We
plateau
also
technique
worked
parce qu'il faut que
to
le plateau technique soit
improve
là pour
the technical
permettre que
aspects
l'offre soit
so that
disponible. Nous avons signé
so
des
that the
autorisations aux
services
structures
are
privées,
available, the
à aux
high quality
structures
services are
privées
available.
pour pouvoir entrer
And with the
progressivement
private sector as
dans l'offre
well,
des
we have
l'interruption volontaire de
done
grossesse.
a lot of
Actuellement, il
programs
y a deux
so
études en
that
cours, et une
we
au nord
can
du pays
be
et une
more
dans le sud
progressive
du
in the
pays
approach.
sur l'état des
And
lieux
in the
de
south
l'offre
of the
des services
country,
d'interruption volontaire de
the
grossesse
services
pour nous
of
permettre de voir vraiment
interrupting
les
the
besoins réels. Quels sont les obstacles
pregnancy
au
by
niveau, tant
willingness.
au niveau des
We have
structures
tried to
sanitaires que
see,
dans
we have
la
tried to
communauté
materialize
pour
and
pouvoir
really
prendre
make a
action
reality.
progressivement
And we
pour
have
que
used
d'ici quelques années,
studies which are
l'offre des
based
services
on these
d'interruption
places
volontaire de grossesse
so that
soit
the
accessible à toutes les femmes et
services
à
of
toutes les
safe
filles.
abortion can be provided to all
Donc,
women
sur le
and
plan
young girls.
social et culturel,
And
nous avons la
so,
signature de
for the
contrats avec les
socio-cultural
organisations de la
program, we have
société
signed
civile
contracts
pour
with
la
the civil
vulgarisation de
society
la bonne pratique
organizations
des
for
communautés.
popularizing
Il
the
y a le
laws
ministre de la Santé en personne qui organise des sessions
that
de
are important
plaidoyer
for
renouvelées
communities.
à
And
l'endroit des
we have organized
parlementaires,
sessions of
des leaders
advocacy, of
religieux,
high
des élus locaux,
level
des cadres des
advocacy in
ministères
the places
sectoriels
like
pour
in
la promotion
parliament,
et la
with religious
soutien à
leaders,
la
with
santé de
local
la
leaders,
reproduction,
with
à l'interruption
ministers,
volontaire de
and we
grossesse
have
et
tried
les
to
violences
promote
basées
and
sur le genre.
provide SRHR advocacy services
Maintenant, voilà très
for the
ramassé ce
benefit
que
of
nous
women.
avons. Nous sommes, le
And
gouvernement
so, just
béninois
to
est en train
see what,
d'entreprendre,
because
mais nous
we work
avons
with the government
beaucoup
of
de défis. Il faut
Benin, but we
reconnaître que
also
depuis
have a
2021,
lot of
on est en train
challenges,
de travailler
and
d'arrache-pied,
we
mais
need to
beaucoup de
tell you that since
défis persistent.
2021,
Et
since the
parmi
law
ces
changed, we
défis,
had a
nous
lot
avons
of
le contexte
challenges that
socioculturel
we
chez nous
try to
qui
remove.
est très
First of all, we
difficile,
have a socio-cultural
vraiment
context in our
contre
country, which is
l'avortement,
very
surtout les
difficult,
interruptions volontaires de grossesse.
and
Donc,
which
il faut
needs
aller
a very
vraiment de
prudent
façon
approach,
intelligente,
advocacy,
de
and
façon
aware and
identifier une approche
sensitivity
très
towards the
prudente
community
pour
for
pouvoir aller
changing
faire
the
des plaidoyers,
behavior, social
sensibiliser
behavior,
les communautés
and
pour pouvoir petit à
gradually with
petit
the time,
aboutir
and also so that slowly and
au
slowly
changement de
we
comportement
can
graduel
change the
dans le temps. Nous ne prétendons
global
pas tout de suite avoir
behavior,
toute la
social
communauté
behavior
avec
of
nous,
the
que toute la
people, so that
communauté
the whole
soutienne cette
community
initiative,
can
mais
hold our
il faut
hands and
travailler
we can
pour pouvoir
work with
identifier
them
les
and we can
approches
help them. But
prometteuses
we
de
need to work and
solutions pour
identify
que
the
d'ici là,
approaches
nous
that can
ayons un
help in
comportement,
putting
le
solutions,
changement
and
souhaité au
so
sein de nos
the social
communautés.
behavior and changes in
La
that is
disponibilité des
important for the
ressources
well-being of community. And availability availability of domestic resources, financial resources is important. And in Benin, it is important that we do mobilization of these resources and strengthening of the public sector as well as the private sector, which is, in fact, it's the private sector which is always present there. For safe abortion services, we need to have strong collaboration between the two sectors. And there is a lot of movement of organization of civil society organizations of NGOs which are working for SRHR. So I think there should be an efficient coordination so that we can maximize the efforts and so that we can capitalize all these efforts and so that we can also achieve our goals in Benin as far as SRHR goes, so that all of our efforts are efficient. And finally, what do we want? What are our thoughts and what do we expect? It is to remove all the sociocultural obstacles and hurdles that exist for in the services for health and reproduction services, and also that can empower women and to mobilize resources. And to conclude, I can say that the time does not stop. Every minute is important to take action, and we cannot lose time. And thank you very much for putting in place an initiative like Kaleidoscope, which can help us, which can support us in making the objectives, in attaining our goals. And you are definitely helping Benin, which is trying to work for women and girls. And together, we will definitely be able to work for the welfare of Benin. Thank you very much.
Thank you very much, Dr. Edith, for your time, energy, travel, and all the good works that the country has been doing in terms of the initiative. Thank you very much. We're now moving towards Kenya with some very strong sexual and reproductive health policies, and being part of important regional SRS protocols. Kenya has set a benchmark in the policy environment for safe abortion access. I now would like to invite Dr. Jean Patrick, Deputy of RMNCAH Division, Minister of Health, Kenya, to kindly come to the podium and share about how the access to abortion landscape has been positively impacted by enabling policies and programs. Dr. Jane is passionate about ending maternal mortalities and morbidities in Kenya. Dr. Jane, for now.
To our chief guests, Director General Dr. Tanka Barakoti, the Chair, Director Family Welfare Division, Dr. Bibek Kumar, my fellow government colleagues from the government of Nepal, Benin, and India, all guests present today, all protocols observed, good afternoon. I would like to present to you our Kenyan context. And it's a very interesting context. We have post-abortion care services in the country. And we know very well post-abortion care services plays a crucial role in addressing complications from unsafe abortions and improving reproductive health outcomes for women in Kenya. Despite the restrictive laws on abortion, post-abortion care is legally available and essential for reducing maternal morbidity and mortality. Post-abortion care services are available. However, they are often underutilized due to stigma, inadequate health infrastructure, and legal uncertainties. In Kenya, abortion is only permitted if, in the opinion of a trained health professional, there is a need for emergency treatment. The life or health of the mother is in danger, or if permitted by any other law. We have done quite a lot to improve service success, reduce stigma. We've trained healthcare providers, and we've done all this to ensure that post-abortion care services effectively contributes to reduction of maternal mortality in the country. The government of Kenya, through the Ministry of Health, has made tremendous strides through development of strategic policy documents. Our maternal mortality is still high. We are at 355 deaths per 100,000 live births. A study done in 2023 showed that we had a total of 792,694 induced abortion cases. And that corresponded to an induced abortion rate of 57.3 abortions per 1,000 women of reproductive age. The induced abortion incidence rate increased from 48 in 2012 to 57.3 in 2023. And I'll be sharing with you shortly why we have that increase in the country. Majority of our post-abortion care clients, those who seek the services, are young women below 24 years, around 42.7%, and those who are above 25 to 34 years, around 41.8%. And abortion rates varied significantly across the regions in the country. The abortion incidence ratio has increased from 30 in 2012 to around 48.1 in 2023 per 100 live births. And this increase is actually attributed to the expanded access to medical abortion drugs over the past 15 years in many settings in the country. And the study also showed that more than half of all the women with post-abortion complications were treated in public health facilities. That is around 50.6%. And 7 in 10 women were treated at the primary level facilities. That is around 69.3%. And it also showed that the regions with the highest unintended pregnancies also had the highest induced abortion rates. How does our policy environment look like? Of course, we have the Ministry of Health, regulatory authorities acts, including CAP 253, 255, 260, and we also have, they are accompanied by their existing rules. As a country, we developed the national Combi Pack, that is mifepristone and misoprostol guidelines in 2023, just to offer guidance on how Combi Pack should be used. We also had the inclusion of Combi Pack in the Kenya Essential Medicine List, which was a big deal for us. We also had, we developed a clinical handbook for prevention and management of the big 5 direct causes of maternal morbidity and mortality. That is also in 2023. And we know unsafe abortion is one of those killers of our mothers. Post-abortion care pocket guide for healthcare providers, we developed it last year. We actually reviewed it last year. And as we speak currently, we are reviewing our national post-abortion care package, which comprises of post-abortion care standards, post-abortion care curriculum, training, manuals, logbooks, and registers. And those are our documents that guide provision of post-abortion care. On the left, we have the newly reviewed post-abortion care guide for healthcare providers. Then we have the Big Five, management of the Big Five. We have the Combi Pack guideline and the curriculum that is under review. On the bottom left, we have the participants manual, facilitators manual, and the logbook. And the black one at the right-hand corner is the register. And what are the outcomes of all these efforts? We have increased access of post-abortion care. The Ministry of Health, in partnership with other stakeholders, has strengthened efforts around post-abortion care services, delivery through expansive training of healthcare providers, and improved supply of essential commodities. In addition, there's an increase in the pack treatment due to increased availability of Combi Pack. We've also improved the quality of post-abortion care. Majority of our public health facilities provide quality pack services due to increased availability of short-acting contraceptives and surgical capacity. The proportion of women with more severe complications have reduced significantly due to improved access to post-abortion care services. And more than 92% of women treated for post-abortion care complications receive contraceptive counseling and services before leaving the health facility. And what is our way forward? We want to strengthen provision of family planning services, including availability of family planning commodities. We want to improve the quality of post-abortion care, disseminate widely the national post-abortion care strategic documents, eliminate barriers to access, especially for adolescents and young women, strengthen the capacity of low-level health facilities to offer post-abortion care services, continue training our healthcare providers on provision of quality post-abortion care services, equip health facilities with appropriate post-abortion care supplies and commodities, and finally strengthen our data management system. Thank you.